Hello and welcome to Envision New Mexico today. This telehealth series is presented by the NOWS New Mexico Quality Improvement Initiative. This initiative focuses on optimizing care for neonates at risk for opiate withdrawal syndrome. This 12-part curriculum is designed to give providers, nurses, care coordinators, and community members content-specific training and education with opportunities for care consultations around this focus. Today we have Dr. Mary Beth Sutter, who is an assistant professor of family medicine at the UNM School of Medicine. Her interests are in group prenatal care for women struggling with substance abuse in pregnancy and neonatal opiate withdrawal syndrome. And I will go ahead and hand it over to Dr. Sutter.
Thank you. So this is the third part on prenatal care. And today I'd like to talk to you about medical conditions in pregnancy, intrapartum, and postpartum care. The objectives of this talk are first to discuss common medical conditions that can co-occur in pregnant women with substance use disorder. Second, to discuss the considerations for timing of and management of labor. And third, to discuss the immediate and longer-term postpartum considerations for women with substance use disorder. So we'll first start with a couple of medical conditions. Hepatitis C is rather common in the population of women with substance use disorder. It is estimated to be between 1 and 2.5% of pregnant women in general in the US. We do know from our own internal data at UNM that it is much higher. So it was about 54% of our Milagro clinic population in 2013 that had an antibody screen positive for hepatitis C, meaning they were exposed to the virus. Among those women, about 2/3 had a PCR positive, so they still had virus circulating in their blood. So that turned out to be about 35% of the entire Milagro clinic population. For women with hepatitis C, it is a very important consideration. Women are often diagnosed for the first time during pregnancy and might not have been aware of their diagnosis prior, and they have great concerns about transmission to their baby and will do anything they can to avoid that. We do recommend vaginal delivery for women with hepatitis C. We don't feel that there is any specific benefit of performing C-section for that indication. Transmission, we know, occurs in about 5% of mom-baby pairs, and that can occur in utero, during labor, intrapartum, does not occur via breastfeeding unless there is blood in the breast milk. So it needs to be a blood-to-blood transmission. We do know that in women who have a primary infection during pregnancy, so they contract hepatitis C during pregnancy for the first time, that there's a higher risk of transmission to the baby and poor perinatal outcomes associated with that. For hepatitis C, in our clinic, we screen in the first trimester or when the woman presents for the first time. We also check liver function testing with the screening, and we will repeat it every trimester if it's abnormal. And this is especially important when thinking about women on buprenorphine opiate replacement therapy, as that can also affect liver metabolism and can alter liver function tests. We do recommend stopping buprenorphine if the woman's LFTs reach 3 times the upper limit of normal, and to monitor those patients closely. During labor, avoidance of invasive monitoring, so fetal scalp electrodes, IUPCs, avoiding prolonged rupture of membranes, and avoiding episiotomies may reduce the risk of transmission in labor, again, because you're reducing the risk of blood-on-blood transmission. And finally, antiviral medications currently are only part of clinical trials during pregnancy. So for the most part, we are deferring therapy for women until after they have delivered. With that said, you can prepare a woman for treatment shortly after delivery by getting the necessary lab work on her, running a genotype, rerunning a viral load in the early postpartum period. so that woman is prepared to make the transition over to a specialist to go through hepatitis C treatment. Cholestasis of pregnancy is more common in patients with chronic hepatitis C because of pre-existing liver inflammation and is an important consideration. We do recommend screening at-risk women with fasting bile acids. And at-risk women might be someone that you know has acute or chronic hepatitis C with elevated liver enzymes, who presents with persistent itching in the third trimester. The fasting bile acid at the UNM lab is abnormal if it's above 10, but it's important to make sure you are familiar with your own lab's abnormal. If someone does have elevated fasting bile acids, the treatment would be ursodiol or ursodeoxycholic acid, and that's taken orally several times a day. We also will give hydroxyzine for comfort for women to help with itching and help with sleep at night. And because we know that there is a higher risk of stillbirth, we will have women go to fetal testing twice a week with NSTs, and then go through induction at 37 weeks to reduce that risk. Syphilis is another common problem that we encounter in Milagro Clinic. There were 6 cases of congenital syphilis in New Mexico between 2011 and 2015. And this is something that is highly avoidable and should not really happen. It can infect a baby with consequences in any trimester. New Mexico is number 20 out of 50 in the state ranking for syphilis infections, so we still have a lot of room for improvement. We recommend screening everyone of the general population in the first trimester and repeating it later in pregnancy if someone is high risk. And high risk people might include someone with prior syphilis infection, someone who has a partner with known syphilis infection, or women who are known to be exchanging sex for drugs. You should be familiar with your hospital screening algorithm. At UNM, we do use a TPAB and RPR reflex algorithm that might be different depending on where you're practicing. Treatment for syphilis and screening for syphilis and knowing whether someone has been adequately treated is very confusing. And so I do recommend, if you are presented with this scenario, to call the UNM PALS line for Milagro or for infectious disease. And that is a great way to talk to a specialist and know that someone is getting the correct treatment to avoid a case of neonatal syphilis. The treatment is penicillin G, and for primary syphilis, that would be 3 injections. And even when someone has a penicillin allergy, it is recommended to desensitize them and give them the penicillin G treatment, as that is the most effective. Mental health disorders are very important to discuss. So they're often comorbid with substance use disorder. Many of the women we see have extensive trauma histories from childhood. They may have started using drugs as a form of self-medication. And if these mental health disorders are ignored and untreated, it may inhibit successful treatment for substance use, may inhibit their ability to stick with their medication-assisted therapy. Counseling is always a great idea, as is psychiatric consultation. And again, PALS would be a great resource to call for psychiatry to discuss a particular case and is available by phone. Medications require a risk and benefit conversation with the woman, and some medications can impact the outcomes of neonatal abstinence syndrome or neonatal opiate withdrawal syndrome. It's also important to note that there is possibly an impact of untreated mental health disorders as well. So this is really a risk-benefit discussion that needs to be had with your patient. In terms of medications, selective serotonin reuptake inhibitors, or SSRIs, are some of the most commonly used medications in pregnancy. We do know that sertraline and fluoxetine are the most studied medications and have the least side effects and least impact on pregnancy and lactation. In the first trimester, we do know that there is a very small increased risk of heart defects from looking at population studies. And in the third trimester, there is a possible small risk of persistent pulmonary hypertension of the newborn, again from a slightly increased risk in women who used SSRIs in population studies. There's also thought to be an infant withdrawal syndrome specifically related to SSRIs, and that would include things like jitteriness and high tone. We don't feel that this is significant enough when combined with an opiate exposure to impact the treatment for neonatal opiate withdrawal. So just because someone is on sertraline in pregnancy combined with buprenorphine or methadone, we do not think that that makes their baby have a worse withdrawal. So that would not be a reason not to offer that to a woman. These medications are also safe to continue in lactation, which is especially important when women are in the postpartum period and at high risk for postpartum depression. You should always use caution in women with a possible history of bipolar disorder, but these medications are actually often safe. So many of our women have been overdiagnosed or incorrectly diagnosed with bipolar disorder in the setting of substance use disorder or in the setting of severe trauma. And often you can screen them for having an actual history of mania. And if they don't have that history, it's often safe to try these SSRIs, and you can often get a lot of benefit out of that for a person with low morbidity. Other mental health medications would include lamotrigine for mood stabilization. This is the best in terms of teratogenicity, tolerability, and reproductive safety profile for actual bipolar disorder. We will start this usually at 25 to 50 milligrams a day and can increase it slowly over several weeks to a max of 200 milligrams a day. If someone has in particular been stable on lamotrigine in the past, then it would be highly recommended to continue them on that. Seroquel we also find helpful for women who have severe panic disorder or have problems with sleep and have PTSD. It can be a safer alternative to benzodiazepines or to Ambien and other sleep aids, and can be given in small doses such as 25 or 50 milligrams at nighttime to help with that condition. Gabapentin is another go-to medicine that we use a lot, and that can be helpful during benzodiazepine withdrawal. We often will use it as a cross taper up while we're tapering someone off of benzos when someone has had a long-standing benzodiazepine dependence, and that can help avoid relapse on benzodiazepines and can lessen the symptoms of panic that often arise in that scenario. And finally, hydroxyzine is very safe, and we will often use this as a go-to agent for acute panic attacks, also for sleep in doses of anywhere between 25 and 100 milligrams at a time. And these medications are all thought to be safe in conjunction with opiate replacement therapy. A great resource for psychiatric medications is the ACOG Practice Bulletin on use of psychiatric medications in pregnancy and lactation. This is a nice chart from that paper. This was from 2008, so hopefully there'll be an update very soon. And just to point out a couple things on here. So it's important to note that benzodiazepines on the top line do have a possible increased incidence of cleft lip and palate for birth defects, and also have infant sedation reported in lactation. So these medications are not recommended in pregnancy or lactation. They can also interact with methadone, and so are not indicated for that reason either. Another note would be lithium actually can be safe in some women, and if you have a patient that has never been able to be stable on anything but lithium, that can be a risk-benefit conversation that medication can actually be continued. And finally, at the bottom, Haldol is another medication that is often very useful for women with severe schizophrenia. We have had several patients continue on Haldol and do really well with that, and there's very few risks to the pregnancy for teratogenicity or neonatal symptoms. If you're ever in doubt, again, there's many resources you can look up. ReproTox is another favorite, which is available through the UNM library. and calling pals to the Milagro doctor or to psychiatry is always a great idea if you're uncertain if you should continue someone on a psychiatric medication or not. We've seen a lot of harm done in the community by stopping psychiatric medications that actually could have been continued, and that can put a woman at a huge risk of relapse. Intrauterine growth restriction is another condition that can arise during pregnancy. There is a known higher incidence with methadone, and it's about 3.48 times greater in the methadone population than average. There's been many studies done to try to figure out this relationship, and there has not been any relationship proven for tobacco smoking, fetal gender, parity, maternal age, or socioeconomic factors. There is one study that related maternal BMI to IUGR, so women with a lower BMI had a higher incidence of IUGR. There are no studies on buprenorphine and growth restriction, but in general, the expert opinion is to extrapolate what we know about methadone. So we do recommend for anyone on opiate replacement therapy to receive screening for IUGR with a growth ultrasound at 28 and 34 weeks. Occasionally, women will need more frequent ultrasounds if there is a problem identified. In terms of fetal testing, it is not a standard at UNM for opioid use alone unless a woman has complications. So if you have a very stable patient on opiate replacement therapy with no other medical comorbidities, that person does not need to come for fetal testing for NSTs or BPPs, anything like that. It's important, of course, to follow your community standard, and in some communities that is the standard of care. You can initiate fetal testing twice a week if you do identify IUGR, and that's a common reason. And again, get those 28 and 34-week growth ultrasounds. There's often weekly umbilical artery Dopplers that need to be done if IUGR is identified. And common induction of labor indications would be IUGR between 37 and 39 weeks, depending on the severity, and stimulant abuse at 38 weeks. Now let's talk a little bit about labor. In terms of fetal monitoring, the standard of care would be continuous electronic fetal monitoring while someone is on medication-assisted therapy. You do want to avoid fetal scalp electrodes with hepatitis C, again, to reduce transmission. And the fetal heart rate with methadone may be affected. So we do see women that have lower baselines like 105 to 110, and sometimes with decreased variability, especially as the medication is peaking a few hours after taking it. So it's important to give those babies some more time. Buprenorphine should not affect the fetal heart rate. In terms of comfort in labor, it's really important to counsel women well that all pain control options are safe with medication-assisted therapy and to have the entire hospital team on board with that. Fentanyl or other opiates IV are safe. Sometimes they will require higher dosing due to dependence. You want to avoid agonist-antagonist opiate agents, which can precipitate withdrawal in women on opiate replacement therapy, and that would be medications like Stadol and Nubane. Of course, women can have epidurals, and they often work very well because there's a combination of narcotic and local anesthetic. And nitrous oxide actually can be very helpful, and we use that a lot at UNM in scenarios where someone might come in precipitous labor and we're not able to obtain IV access in time to do anything else. And all those are safe with medication-assisted therapy. You should also do everything you can to maximize non-pharmacologic methods, and that would include things like allowing women to get into the bath or the shower, birthing balls, changing positions, aromatherapy, music, having someone that supports them in the room, whether that be part of the healthcare team or their own family or a doula, and that can make a big difference for women. In terms of labor support, our women do have a lot of prior trauma histories, and so labor can sometimes be a very difficult experience. They also might have estranged themselves from their past friends and family, and so they might have poor support when it comes to the time where they're ready to have their baby. Doulas are ideal if those are available in the community and affordable, and we're working on getting a community doula program for our Malaga population at UNM right now. A continuity provider, so a midwife or a doctor delivering the baby, can make a huge difference in the experience for women if someone has seen them through prenatal care and is then able to attend their birth. This is a population that has many issues with trust, and especially trust with the healthcare system. And so it means a lot to women when their doctor shows up and advocates for them. You should also note that incarcerated women might have the healthcare team as their only source of support. So if they are in labor while incarcerated, they're not allowed to have contact with family. Many times the family will not even know that they're having their baby, and they're certainly not allowed to be in the room with them. So it's important to be an advocate for your patient in that scenario. And so having a continuity provider come in, advocating sometimes with the guards to remove shackles will also really help make a big difference in a woman's experience if she does have to deliver while incarcerated. And unfortunately, that is rare, but it does certainly happen. Some special anesthesia considerations with medication-assisted therapy. So continuous epidural infusions for greater than 24 hours may benefit some women who have trouble with post-op pain relief. That is something we've been trying lately at UNM. So to put in a combined spinal epidural at the time of C-section and to leave that epidural in for 24 hours postpartum with medications running through it. Some anesthesiologists are reluctant to use long-acting spinal morphine or Duramorph in conjunction with opiate replacement therapy due to concerns about overdose. Some people will be comfortable with that, and sometimes it does work well. It's important to note that women will require higher doses of post-op pain medication. So, for example, a normal regimen might be 10 milligrams of oxycodone every 4 hours around the clock, plus an additional 10 milligrams available for breakthrough pain. And if that is not affecting a woman's sensorium, then it's important to assess her for ongoing pain and increase the dose of the narcotic if needed. Some women may be resistant to oral opiates when they are recovering from C-section because they've had past issues with pill abuse, and so they should be offered maximum therapy that is non-opiate related with ibuprofen and Tylenol and other techniques. And now postpartum care. So medication-assisted therapy postpartum is relatively easy. You should continue at the same dose as postpartum. You should convert Subutex over to Suboxone, and most insurance companies will stop covering Subutex around 6 weeks postpartum as well. Methadone may need to be lowered in the first few weeks postpartum due to oversedation. So a lot of women, once they do not have their placenta anymore, their sensitivity becomes a lot higher. And so they might need to lower their dose if they are finding themselves to be oversedated during the day. Continuation of medication-assisted therapy, we know, prevents relapse during a stressful time. So new motherhood is stressful for anyone, but in particular stressful for women with substance use disorder who have lots of big changes going on in their lives. In the hospital, doctors treating the baby should be aware of mother's needs. So moms may need to leave the hospital, may need to leave their baby's side to go to methadone clinics to get their medication, to go to the pharmacy to get their Suboxone, to go to postpartum appointments, and they might be required to have more frequent postpartum appointments than the average person. So communication with the neonatal team is very important. When considering incarcerated women, a lot of prisons will not allow continuation of medication-assisted therapy once a woman is no longer pregnant. So first and foremost, figuring out if that's allowed by calling the prison. And secondly, if someone is not allowed to continue on their opiate replacement therapy, then you should taper it inpatient to be the most kind to the patient. Often this works out really well because then they can be with their baby during that time and help the baby with their baby's withdrawal. Postpartum depression is higher in this population than in the average population. And a lot of times that's because women may have isolated themselves from friends and family who are not supportive of their recovery. Consider starting SSRIs in the third trimester if you do have a patient that you know is at high risk. So someone that struggled with depression before, or even postpartum depression before, that might have been reluctant to do psychiatric medication early in pregnancy due to fears of teratogenicity. A lot of times starting in the third trimester can allow you to get that 6 to 8 week therapeutic window, so women are safe and have that on board when they are at risk for postpartum depression. Medication-assisted therapy should continue for several months at least. It's a common thing we hear that women want to try to get off of everything as soon as they have their baby, but this is actually probably more stressful for them. So we recommend at least till a 3 to 6 month postpartum period, and then to consider tapering off at that point if they are very stable. You should also look in the community for support groups for women. So we do have several available through our methadone clinic, and I'm sure around the state, even postpartum groups for everyone can be beneficial for women so they can make a social connection with other mothers. So La Leche lead groups and things like that as well. In terms of contraception, long-acting reversible methods, so IUDs and Nexplanon, that can allow time for recovery. Immediate post-placental IUDs are safe in breastfeeding, and Nexplanons as well, and those can be placed in the hospital prior to discharge. There is a higher rate of expulsion with immediate post-placental IUD, but if you have a patient that you think is at high risk of not coming for a postpartum appointment to get that IUD, then placing it immediately can be a great idea if they're amenable. There may be a high rate of regret of sterilization in women under 25, and this is something that's important to counsel about. So we see a lot of women who are very young going through recovery, wanting tubal ligation, and then several years later, they might be in a completely different place in life and they want another baby. So it's important to give that woman counseling. LARC methods are so effective, but they are reversible, that is a really great alternative to give someone some more time for that decision. So conclusions of this talk. First, there are several complex medical problems that can complicate pregnancy with substance use disorder, and it's important to keep an eye out for those. Labor management is mostly the same. Special considerations for pain relief in labor make a big difference in a woman's experience. And finally, the postpartum period is a time of high risk of relapse and need for support. And that is all. Thank you.